So today I was thinking, how can I give you guys enough? I just want to make you so comfortable with prioritization that it's not that bad, because most of the test is all prioritization. Even pharmacology, what do you prioritize? Everything. So I sat down and I made things up. Okay, I made it up. Okay, but it's diagnosis that you should worry about. And just give me time to go them. There's about 49 of them. We're not going to do all of them. We just do some actual questions. But I want to show you how you yourself, when you study, you should start doing that. Start making things up and see, so that you can worry. You can write questions. You should be able to write questions. And this is what it looked like, a bunch of them. Who is a priority? We read it and then you tell me, and I'll tell you who is a priority. But these are the things I just want to, it's a review of main diagnosis, main condition that usually pop up all the time, and what you should worry about, what they can trap you with. So we have a client with flank ecchymosis after kidney biopsy. Okay, the kidney is on your back. We did a kidney biopsy. All of a sudden, they have flank ecchymosis. So the kidney is here. So they can have flank ecchymosis or periumbilical ecchymosis. When you see that after kidney or liver biopsy, patient is bleeding. So this patient is bleeding. Do you want to see them? Yes, you should. A client with back pain after cardiac catheterization, I forget it after. The same thing we did. Back pain, cardiac catheterization, think about bleeding. Every time you see this is the way they're going to set it. These are classic testable questions they like. When you see it, this is in shock. So it's bleeding. The client laying on the left side after liver biopsy. When you get liver biopsy, liver is on the right upper quadrant, okay? When you do the liver biopsy, it's a vascular organ. When you stick a needle to that, it's going to bleed. After the procedure, we got to hold pressure, but we cannot hold pressure because it's way down. We can't feel the pressure. So what do? You put the patient on the right side. So they lay on the liver, which is on the right side. So they should lay on their right side, not on the left side. If you see a patient with the liver biopsy laying on the left side after biopsy, it's a priority patient. You should say, no, I need to see this patient because they will be in shock. So this is a priority patient. This is a priority patient. And this is a priority patient. A client with lung cancer and a urine specific gravity of that is vague. That's the way they will set it. Then you say to yourself, how does lung cancer have something to do with the what? Specific gravity? Then it will occur to you with the good content that you're going to have, there's some lung cancer that secrete ADH. So ADH, SIDH, usually not from your brain. It can come from infection. It can come from tuberculosis. They will give you infection, tuberculosis, somebody who have brain surgery, or somebody who have lung cancer, small cell lung cancer. That's the number one. Small cell lung cancer will produce ADH. What does ADH do? Go and absorb all the water from the kidney. So you can do what? Pee. When you pee, your pee is concentrated. So we put this patient in SIDH, concentrated urine. And your specific gravity is what? 1.003 to what? 1.030. This is what? 1.033. What do you think? It's too high. And this is consistent to SIDH. It should be greater than 1.030, and this is 1.033. Therefore, should you worry about this? Guys, tell me, should you worry about this? Should you? You shouldn't worry about it because you expect SIDH for urine specific gravity to be high. You should not worry about it. That is normal. That is an expected finding. So that is the trap. I intentionally put it there, but that is the thinking you have to do. SIDH, the urine specific gravity is high, and it should be greater than the higher normal. 1.003 is the lower normal, 1.030. This is 33. Therefore, this is higher than the higher normal. So you expect specific gravity to be high. That is what they've given you. Don't worry about it. I'm not seeing this patient. That's expected. If I give you sodium, I said sodium is what? Yeah, 120 something. Yeah, but these numbers I've given you, you know they have SIDH, but the problem we're looking at is consistent with what I expect. If I give you sodium, yeah, sodium 125, then you should go and worry about it. But 1.033, I give you a specific gravity, that is what you expect from the patient. I've not given you the sodium, what the sodium is. I just give you the specific gravity. If I give you sodium of 120, yeah, but they can have this and your sodium will be like 135. It has not gone down yet. So you work with what you've given. This is what I expect for their specific gravity to be. So that is the trap. Okay. Now, a client with left pleural effusion and decreased breath sounds on the left. What do you think? You have left pleural effusion. This is your lung, and there's fluid there. It's pushing on the lung. And then when you listen to them, there's decreased breath sound. That is what I expect because there is there is fluid there. It's supposed to decrease. I've not told you that patient is in shortness of breath, is in respiratory distress. All you have to work with is what they've given you. They've not given you anything. I just tell you that, oh, left pleural effusion should have decreased breath sound. But the patient is not desaturating. Nothing is happening to them. I don't overthink it. This is what I'm telling you. Therefore, I expect breath sound to decrease. So I'm not worrying about this patient. The client with left femur fracture and petechia on the chest. This one, I want you guys to do for me and tell me what it is. So buzzwords and clinical diagnosis. I'm using buzzwords and clinical diagnosis. Yes, everybody said you should worry about this because this patient has what? You have to make the diagnosis. It's the same thing you're going to do in the new generation questions. Left femur fracture and petechia, you should be thinking about what? Fat embolism. They have bone fracture and there's petechia, small blood vessels that is bleeding on their chest. That is petechia. It's a sign of fat embolism. They can have change in mental status, petechia, hypotension, and respiratory distress. These are signs of fat embolism, but they won't give you everything. They'll give you a fracture or confusion, fracture and confusion, fracture on petechia on the chest. That's the classic way of presenting it. And this is a priority patient. A client with pneumothorax and tidling in the water seal chamber. Should you worry about this? I know he has pneumothorax, but that's not a problem, right? That's not a problem at all. That's not a problem. Pneumothorax is not a problem. But what is happening? We have a chest tube in place and he's tidling. If I have chest tube in and he's tidling, that means he's working. Just having pneumothorax is not enough. I'm treating him with the chest tube and the chest tube is tidling in the water chamber. So it's perfect. I'm treating the problem. I'm not worried about it. Don't let the pneumothorax like strap you and say, oh, pneumothorax is dangerous, so I have to pick it. No, don't pick it. A client with drooling and restlessness after sore throat. What do you think? There's two buzzwords there. And what is the diagnosis? Sore throat and some drooling and restlessness. Sore throat, I worry. I said, sore throat. Now, drooling and restlessness. This is epiglottitis. And that's airway emergency. With drooling, yeah, we have an airway problem. You got to see this patient. Those are the buzzwords. They will give it to you. So buzzwords, we're dealing with buzzwords all day long. Watch those words, watch them, and pay attention to them. A client with rhinoid disease, okay, and blue fingers after cold exposure. That's what you expect with rhinoid. Any extreme temperature and temperature will cause vasospasm, and your fingers will turn blue. And so that is normal. How do you treat it? Calcium channel blocker. If they ask you, calcium channel blocker, topical calcium channel blocker, you just put it on your fingers when it happens and they do fine. Or you tell them to avoid stress. But that is normal. Don't let the blue thing make you worry. It's blue, fine, but that is what will happen with rhinoid phenomenon. Okay, I get you guys hot now. A client with calf pain when walking, which resolve with rest. He has calf pain, okay, but that happens when what? They walk, and then it will resolve at rest. What do you think? This is not DVT, don't choose it. It's not DVT. When you walk, you have calf pain, it's ischemia. Basically, you're asking for blood that is not there. And so they start hurting. When you stop, it get better. Claudication. Should you worry about it? No, it's not a priority patient, but you know probably they have cardiac issues too if they have peripheral vascular disease. But you don't have time. Among these 10 patients, no, you don't have to worry about that patient. So this is the first 10 of the heat. Any question so far? That's what I wanted to pay. I just sat down and I made it up. Okay, I said, what is the best way to leave you guys with, like, and seeing some people still have issue with prioritization. But that is the way. When you start learning, reading, and trying to boil down as you get closer, you say, oh, this is the diagnosis. These are the things I should worry about. This is the way they will present it. That's the way they're going to ask you. You know, they will trap you in some of them, but some of them you should expect, you know. You work with what you give them. Yes, okay. A client with right heart failure.
Okay, please.
And BMP of 1,000. What do you think?
Get me
This is what the definition of heart failure. Just because he has a BMP of 1,000 doesn't mean you should freak out. The number is high. Heart failure, you should have a BMP of greater than 100. The definition of heart failure is a BMP greater than 100. It doesn't matter anymore whether you are 1 million BMP. This is what I expect to see. Therefore, I don't see this patient. If I tell you he has pink fluid sputum, yeah, he has pulmonary edema, then you should worry about. But just having heart failure is not enough. People walk around with heart failure all the time. They come to the hospital without any problem. We don't say anything, right? A client receiving blood transfusion, complaining of back pain. It's not good. There's 3 things that happen with blood transfusion. We have febrile reaction, we have hemolytic reaction, and we have allergic reaction with shock. The febrile one is they will have fever. That's fine. Sometimes they will tachycardia and respiratory rate is high. You have to get this right. Febrile reaction, they have fever, white count, tachycardia, sometimes a little bit of blood pressure will drop. That is okay, but you got to stop the transfusion, assess them, but it's not something emergency. Okay, you have to stop it, and then, but because it's something you expect to happen, but you have to see them, stop the transfusion, let the doctor know, give them some Motrin, and that take care of it. Having back pain, when they start having back pain, chest pain, that means they're having hemolytic reaction. That is dangerous. That patient is having hemolytic reaction, is dying and bleeding. Then if they start having airway issue, bronchospasm, you take here, rash in their body, all of them, those become allergic reaction. And if they put anaphylactic to it, it becomes shock. So you got to be able to distinguish between them. Back pain is hemolytic, bronchospasm is allergic, anaphylactic reaction. They're all different. So this patient you have to see is bleeding and is having hemolytic reaction. A client on amiodarone, intractable cough. Anybody on amiodarone and is coughing, you have to see them. That's pulmonary fibrosis. That's the way they're going to tell you. They're going to ask you the priority issue for that problem. If they give you liver LFT increase, don't see it. If they give you TSH that is high, don't see the patient. So they will have what we call P-clone. They will have pulmonary fibrosis, cardiac issue, liver issue, hearing issue, neurological, and dermatitis. All of them, the only most important thing is pulmonary fibrosis. If they give you AST of 500 because the liver is affected, yeah, it's not a priority patient. TSH, they have hypothyroid issue, don't worry. All you care about is pulmonary fibrosis. Every time they give you a amiodarone question and there's no coughing or pulmonary fibrosis, or they don't put PFT there, yeah, then you got to go to the next level. We may be the cardiac one, but they're going to ask you priority. So this patient is a priority patient. A client on digoxin with nausea and diarrhea. What do you guys think? Do I see this patient or not? He has GI symptoms. All the drug with therapeutic level that is really narrow, any GI symptoms is a priority. Lithium, priority. Theophylline, priority with the GI symptoms. Therefore, you should see this patient. I'm just giving you the key information. It's like just a summary, but you got to, if you forget them, yeah, digoxin is a priority. A client on nitro patch placed over shaved skin. So he has a nitro patch for probably angina. And the way he put it, that area is shaved completely. Should you see this patient? Yes. They should not shave that area because now they take all the air out, they'll break the skin, you put the nitro, and then you release all the nitro into your bloodstream subcutaneously. It's not supposed to. There's the reason why it's a patch, is to deliver slow nitro. If you put it to an area that is completely shaved, there will be skin cut, and now it can absorb faster. So you should see this patient. A client on nifedipine with grape juice on the dinner table. Guess what? That's a priority patient. Calcium channel blockers should not take grape juice. That's the key. If you have calcium channel blocker, you should not take grape juice. Why? They all break down by CYP34A. You don't need to know this. Sorry, but I just have to. You don't need to know it, but that's the enzyme that break it down in the liver. If you take grape juice, it makes this guy ineffective. And so they have toxicity of the calcium channel blocker. So they should not take grape juice. No, negative. So you have to see this patient. The client on metoprolol, heart rate of 61. Guys, tell me whether you want to see this patient. You should not worry about this. The definition of bradycardia of your test is 60. Anything 60 and below. 61 is still within normal. Just don't freak out. Don't like, oh, 60 is close to, 61 is close to 60. Yes, I know it's close to 60, but it's not 60. So don't pick it. A client on lithium and taking Motrin for pain. What do you think? In taking lithium, you avoid anything that will affect your kidney. Motrin affects your kidney. So stay away from Motrin. Stay away from dehydration. That's all. So we got to see this patient. A client on INH and report of numbness and tingling of the hand and feet. So this is isoniazid. It's a TB medication. And the patient is reporting numbness and tingling of the hand and feet. What do you think? Would you see this patient? That's another trap I put there. The side effect of isoniazid is peripheral neuropathy. That's another trap. Peripheral neuropathy. And what is peripheral neuropathy? Pins and needles, numbness and tingling of the hand. So don't worry about this. What is the treatment? You give them what? B6. Go and take B6. You'll be fine. So don't give them, don't worry about this problem, peripheral neuropathy. Okay? Pay attention to it. It's not a problem. So isoniazid, you get a peripheral neuropathy. That is an expected finding. So don't worry. It's a trap. I intentionally put it there. A client on dicyclomine and Terminal for glaucoma. Should you worry about it? If you have glaucoma, you should not take anticholinergic. Dicyclomine is anticholinergic used for IBS, and that can worsen their glaucoma. And so you should not do that. And then this is just the first portion of it, 20 of them, just to like get you guys thinking. I have a bunch of them. I mean, if you guys want me to keep going back, we can go to another, but we can, let me see, maybe 10 minutes and